that I introduce the first speaker for the afternoon. A speaker who really doesn't require any introduction, is well known to many of you, I would say a real friend of this meeting. The second time in a row he's been here, Dr. Michael Keating from the MD Anderson Cancer Center. He is again, just one of the most influential and important researchers in CLL, has been awarded numerous international awards, pioneering work in the development of chemoimmunotherapy, and we're really grateful to have him here to provide an American perspective on the management of CLL. So a warm welcome for Dr. Keating.
Well, the Leukemia Lymphoma Society not only looks after people with CLL, but they also look after kids. And when I walked in here, I thought it must be the pediatric group. But then I thought, no, it's not that. So it must be the grandparents of the pediatric group, and that's more relevant. But one of the disturbing things about listening to Dr. Halleck is every time he speaks, I figure that I've gone from being a go-go to a slow-go, and whether I'm going to end up in the next couple of years as a no-go. So it's a humbling experience. Just to let you know that a number of years ago, Professor Benet had the French cooperative group, and that was the #1 cooperative group in the world because of his particular personality. And the Germans have now become the #1 cooperative group in the world. And really it's because of the efforts of Dr. Halleck. He's truly an outstanding organizer and has done some wonderful things internationally to help us develop a number of these programs. So I had this funny title with a term in inverted commas, and that's this cure thing. Because in the introduction where I mentioned that CLL is the most common leukemia in the Western world, the next sentence in all of the chapters, it's an incurable condition. And that's what they used to say about childhood leukemia, but childhood leukemia is now routinely cured. So perhaps we just have to say that all the incurable diseases are just pre-curable and, until we get the right treatment for them. So many of you are very happy at the present time because your disease is controlled, and control is good, but eradication of the disease is better. And if we can actually then return you to a state of normalcy, that would be even better still. So this is the FCR program, and the reason that I put it up here is because it's based on some sense that the alkylating agent is cyclophosphamide, which is the most flexible of this group of drugs, more flexible than bendamustine. And also fludarabine inhibits DNA repair in the malignant cells so that they can't escape the effect of the alkylating agent, and fludarabine is very potent in its own right. No one really expected the addition of rituximab to be as dramatic as it is in improving the outcome. But I put this up because these are a few slides that are going to be in a manuscript that we'll be submitting for publication in the next week or so. And this is the updated progression-free survival and overall survival of the initial 300 patients that were treated with the FCR program. And it used to be, in most of the slides that you saw there were survival curves in weeks or months. But as you can see, the survival curves in CLL are now getting out to years. It used to be up until the FCR program came along that the median survival of patients on clinical trials was about 5 or 6 years. And the median survival of this this group of patients has not been reached. Now, the median survival is when 50% of the patients would be expected to die, and this is where the survival curve looks. I've been asked to illustrate what these little tick marks mean, and that means that these patients are still alive at the time that they're being followed, and every time there's a fall in one of the curves, that means that some adverse event has gone along, and this is how the statisticians present it. Also, the median progression-free survival used to be around about 3 years on average, and now it's out to 6 years. So progress. But you'll also notice in that progression-free survival group that apart from one patient late at 14 years, almost all of the patients from 10 years on have not progressed and have not died. And when we look at the main reason for this, as Dr. Halleck illustrated, the patients that have a mutation of the immunoglobulin gene, which is a normal process in B cell development, this group of patients has an outstanding long-term survival, so that about 60 to 65% of those patients have never had any recurrence of the disease. And when we measure in this mutated group to see if we can find 1 in 10,000 cells in the blood, we can't find any leukemic cells. So what's the definition of cure? Well, if you said to someone at the start of the FCR treatment, would you be happy to be free of evidence of disease at 10 to 16 years, would that be an acceptable cure definition? I'm sure most people would say yes. The fact that most of the patients with CLL are in their Medicare eligible age group means that this has actually extended their freedom from disease for a long period of time. But you'll also see in the blue curve that there is a pretty relentless fall-off in the time to treatment failure or progression-free survival. So that this is a group of patients that we really do need to develop true new initiatives. Now, this was done before the era of having these FISH analyses. And the term FISH means fluorescent in situ hybridization. So the problem is that CLL cells don't divide when they're taken out of the marrow, so that you can't do a genetic analysis on the chromosomes because they're not unraveling so that you can count them. So that you had to develop particular unique sequences that you could layer onto the cells and see if they had the right number of little fluorescent dots. And the abnormalities that Dr. Halleck mentioned was abnormalities in chromosome 11, 12, 13, and 17, and the probes measure all these things. So in the era from 2004 on, we had this information on the vast majority of patients, and during that time, we were trying to improve the efficacy of the FCR program. So we tripled the dose of rituximab, and it didn't work. We added mitoxantrone based on some data from our lab and from a clinical trial in Spain, and it didn't work. We added alemtuzumab or Campath to the FCR. It didn't make it better. We added a GM-CSF to it, and it didn't make it better. So from that point on, we just stuck with the tried and true FCR program. So the time to treatment failure by these FISH groups is illustrated here, and whether they were mutated or not. So this is the test moving forward as to whether the mutation analysis worked. And the top curve is those that had the mutation. And as you can see, as time goes on, the curve is beginning to flatten out and has a very similar outcome to what we saw before. We have in the pink, or perhaps ladies would call it fuchsia, and the patients in the fuchsia fail and go on to other things. The green curve is those that have abnormalities in chromosome 11, and even though they have a very good response, as Dr. Johnson mentioned, they become negative for MRD, they still all relapse. And then there's a subset of patients with other changes that appears to be able to go on. And again, because they respond again and again, many of these patients that are unmutated actually do very well because you can get another remission. But the group of patients that have the loss of part of chromosome 17 with loss of a particular gene function called P53, they stand out as something very separate. And the great thing about ibrutinib and idelalisib and ABT199 is that all of these targeted therapies work on the 17p group of patients. So we already have a better outcome for that group, and the next target group are the patients that have loss of chromosome 11 to see if we can get to the point where we don't have any recurrence of that particular group. So why do we want to get away from that? Because we've made such good progress. And one of the problems is that the patients that end up dying of CLL, almost half of them end up being associated with another cancer. So that the question is, does the chemotherapy cause the cancer, or do patients with CLL have a higher likelihood of getting other cancers? And that's partly true for both. There is a higher incidence of other cancers, of about a third more likely than average to get every subset of cancers compared to the average, except the acute leukemia transformation, which occurs in about 4 to 5% of patients that are treated with the FCR program, doesn't occur unless you have the chemotherapy part. And the Richter's transformation going into a large cell lymphoma has a very low frequency unless you have a chemotherapy program. And almost 3/4 of the patients that actually die in their first remission end up dying because of some complication. So that one of the things that we've tried to do now in patients over the age of 65 is to look at the what happens in the era of 2008 onwards and say, okay, if we can get away from chemotherapy, if we have a protocol available and we treat them with antibody regimens, as you see down the bottom, or lenalidomide, which is Revlimid regimens, or some of the new targeted therapies, compared to at the same time when we didn't have a treatment option for them, and we put them on an FCR-based regimen, does anything good happen? Well, the incidence of the solid tumors doesn't change. So I think that's just part of the association of the solid cancers along with CLL. But we do have a significant decrease in the Richter's transformation if we don't give them chemotherapy, and we have a halving of the likelihood of them getting an AML or myelodysplastic syndrome with time. So that we're beginning to try and identify the patients that are at risk of getting these complications so that we can increasingly get away from that. So after we analyze all this, what are the things that are problems? And Michael alluded to a number of these things, that the older patients don't tolerate the chemoimmunotherapy as well. That doesn't mean you can't do it, because there are groups in Israel and Australia that have modified the intensity and shown that if you just drop the dose down or extend the intervals in between, they can actually tolerate it quite well and have a very good outcome. But we do have these genetic changes that we haven't solved, the second cancers we haven't solved. But one of the things is that when you go into treatment of the CLL, you have a disturbed immune function anyway. Almost every element of the immune system is somewhat decreased. And that doesn't mean that you're a walking time bomb that's going to get some dreadful infection, because God has been good to us. He's built a lot of redundancy into the systems. So even though it's down low in some areas, the risk of getting a particular infection is actually pretty low. But one of the key things that we have to do now, if we're getting rid of the leukemic clone or the family of CLL cells, how do we go about rebuilding the immune system? And that's something that is being put in place now. And we'll probably be able to have a fairly effective way of markedly improving the immune system within the next 18 months or so. So we have a number of different ways that we can do it. We can do these, the B-cell receptor antagonists, the ibrutinib and idelalisib. The IMiDs, immune modulating drugs like lenalidomide, and there's another one that's coming along that appears to be 10 times as effective in stimulating the immune system. We can develop some things that are looked at in the lab to develop more rational combinations, and Dr. Plunkett and Dr. Gandhi in our institution are doing a lot of this. But before we were postulating that we were potentially curing some patients with chemoimmunotherapy, the only thing that was curing CLL was a stem cell transplant. And it was curing them because we put in a new immune system. And the new immune system killed off the leukemic cells because it would recognize them as foreign. So the thought now is, can we teach the patient's own immune system to do what a foreign immune system can do? And this, I think, is going to be the commitment that will occur in the next 18 months to 2 years in the United States. And as I more rapidly approach the age of 75 years, we don't have anything that's terribly damn good for that. So it just means I have to stick around and work really hard. Otherwise, I'll just be abandoned, stuck in a corner in a rocking chair and drinking red wine and reading mystery novels. Lenalidomide has been largely ignored, and it's partly because the company hasn't been very interested in it in CLL. But I find it a fascinating drug. It's very effective in myelodysplastic syndrome, in multiple myeloma. And if you start off with a very low dose, and in fact, in frontline therapy, one of the first publications on this came from Toronto. But if you start at a very low dose, you can actually get a very good response. It's a medication by mouth. And one of the things that's of interest is, even though that in the chemoimmunotherapy, the patients with an unmutated immunoglobulin gene have an inferior survival, there's no impact of the mutation status of the immunoglobulin gene and survival of the patients that are being treated with these immune modulating drugs. And it was mentioned this morning, I think, by Graham or Dr. Johnson, the improvement in the immunoglobulin levels, which is a feature of CLL. The normal B cells are not making gamma globulin, but as you can see, the IgM and the IgG actually go up over time. So that's an element that we can do. One of the discussions this morning was, do we have a good response to vaccines? Well, we just put in place a protocol where patients that have finished therapy, we're going to be vaccinating them together with lenalidomide to see if we can improve the antibody response to the flu vaccine, the pneumonia vaccine, etc. So if we start off and look at the patients that didn't get the FCR base is in the green, so that if we start off with these alternative therapies, if anything, there's an improvement in outcome rather than a negative impact in outcome. So I think that rather than getting away from the one-size-fits-all, I think we have to figure out what the lesions are, what the genetics are, and see if we could approach it specifically. So over time, what's happened is that we've been getting away from starting patients off on the chemoimmunotherapy, so that the patients from 2004 on, the number of patients is in the blue, and the percentage of patients that were starting off on an FCR base has been continually going down. One of the problems, however, that we have is that the new agents are under the control of the pharmaceutical companies. They're very, very expensive drugs. The insurance carriers don't like you doing investigational studies with combinations of expensive drugs. so that we don't have the flexibility that we would like to have to get to the point where we don't need to start anyone off on chemoimmunotherapy. And this is something in North America, both above and below Niagara Falls, that we need to work on our governments to start saying, look, at least have a stash of drugs so that investigators can do things that they think are smarter than the insurance carriers think. We've been getting some background information so that we've looked at patients that are 10-year survivors of CLL in our patient population, and the group in Winnipeg have their 100 or 200 patient studies. We have 470 patients, and we've looked at the patients that had cancers before they were diagnosed as CLL. And if you have some other cancer, you're more likely to develop CLL than if you don't have a cancer. But there are only certain ones. So we're going to set up a clinic within a clinic so that everyone that comes back to the MD Anderson every 6 to 12 months will have a full evaluation of whether they've had the required cancer screening test. We'll look for their skin cancers, we'll look for melanomas, and see if we can prevent these things from happening. So the wonder drugs, well, we have a list of them here. The Bruton and idelalisib have been approved, the obinutuzumab, the new antibody that Dr. Hellick spoke about, and the ABT199, and none of them are free of challenges. That doesn't mean that they're problems. They just have to be handled. But about 5% of the patients with the Bruton will develop a new atrial fibrillation. And the reflex there is to anticoagulate the patients, but unfortunately, ibrutinib is associated with platelet dysfunction, so that you have a coagulation abnormality and a platelet dysfunction, which is a bit of a challenge, and the patients still develop a Richter's transformation. Sometimes idelalisib patients have GI problems and some pulmonary infiltrates, and even the ABT199. The major cause of failure of that regimen is the development of various forms of Richter's transformation. So as mentioned, ibrutinib came along and was approved for a variety of studies, and it inhibits the particular enzyme BTK, Bruton's tyrosine kinase. And Bruton described this defect in young boys, that they had a mutation in the gene, so they couldn't make this BTK enzyme, and they couldn't make any B cells, and they couldn't make any gamma globulin. And ibrutinib was designed to inhibit the active site of that particular enzyme. And it's proven to be remarkably effective. The protein to the left of it, the PI3 kinase delta, is inhibited by idelalisib. So it's a very effective inhibitor of this when it gets in there and it tightly binds. But as mentioned, if you have a mutation in the gene, you can mess up the binding site so it's not as tightly bound, and that's one mechanism of resistance, but it's not the only mechanism. So we're still learning how to most effectively give this drug and the most effective dose. As also mentioned, the absolute lymphocyte count will often go up quite dramatically from 20,000 here up to about 65,000, and then gradually go down over a period of time. And over in the right, you will see these big chunky areas of lymph nodes in the front or the upper part of the curve in the armpits, and in the lower one a couple of months later, they've all disappeared. So the most impressive thing is how rapidly the lymph glands go. And there's a lot of diversity in how long these cells circulate. And it's related to a degree with the FISH test, the genetics. The trisomy go up quite promptly, and a week later they go down. And 13Qs will hang around for around about 12 to 18 months. So again, we're just learning how to handle this. But the impressive thing is how many patients respond. So as you can see, even in the first clinical trial, and in a phase 1-2 clinical trial, to get a response rate of 80-something% was almost unheard of. The investigators thought that The independent response committee was a bit tougher and dropped it down to 65%. But these patients were when we're still learning how to use the drug, and the response rate really is over about 80% for almost everyone. And the top curve in the blue is if you give the drug as initial therapy, and there's only one patient who failed, a patient of Dr. O'Brien's who developed a Richter's transformation, so that it appears to give very long control as a single agent when given frontline. If they're relapsed and refractory, that is, they've had a number of other treatments before or have had a response and then the disease has come back in the yellow curve, there is a drift down, which is, again, related largely to the 17p group of patients. See, one of the problems that we have is that many of the clinical trials that lead to approval are designed by the companies in conjunction with the regulatory agencies, and the regulatory agency says, we will approve your drug if you test it against this. And what they tested it against was an intravenous antibody called ofatumumab or Azera, and this was the RESONATE study. And the progression-free survival was obviously the endpoint and dramatically in favor of the ibrutinib in that top curve. The survival didn't show a dramatic difference, but it was a significant difference. And again, most of the fall off in survival that went from the top curve down to the bottom curve occurred within around about 3 to 7 months. And that was because there was clumsiness in the crossover from the antibody when patients were failed to get onto the drug that we knew was better, but we had to go through the motions. But as you can see, these patients have continued to do very, very well. Now, when people say, well, this chromosome 17, everyone does badly, well, that's not actually true. You can see that in our experience with a whole range of ibrutinib studies, we presented this at the American Society of Hematology last year, and the green curve of the 17p group of patients, and the others are the 11qs and the others, and they're no real difference. So the 11s do fine, but the 17ps have not done very well. But one of the things is that we also looked at whether there was a lot of damage to the chromosomes on any of the patients going on study, and those that had the most damage, that is a complex karyotype, with a group that did very badly. And the problem is that most of the 17ps have a lot of DNA damage, and that's the group that doesn't do well. The 17ps, if they don't have DNA damage, do as well as everyone else. So we've gone away from doing conventional cytogenetics on the marrows because it wasn't terribly helpful initially, but now we think that we can identify a lot better the group of the 17ps that's actually going to do better. So we can draw a number of conclusions about the ibrutinib. It's very good in decreasing the total amount of CLL, because the CLL cells that are circulating in the bloodstream are only about 2% of the total amount of CLL. The rest of them are in the bone marrow, the spleen, the lymph glands, etc. And because they shrink so dramatically, you dramatically decrease the total amount of CLL. I've already mentioned the 17p improvement. It is very, very uncommon to get to the point where you can't find any CLL cells. So there's always this family of cells that's left behind, and the target for us now is to get rid of that. And I think the most effective way to get rid of it is going to be teaching the patient's immune system to be able to accomplish that. There was the study of idelalisib was rituximab alone versus rituximab and idelalisib. I hated that study, refused to put any patients on because I knew that the control arm was ineffective. And it was proven to be ineffective because the red curve is how quickly they responded, and there was a survival advantage because we couldn't salvage them quickly enough with the idelalisib. And unfortunately, we have to use idelalisib and rituximab. As Dr. Johnson said, every time you add rituximab to a regimen, you add another $50,000. So do we have to add it to every regimen just because the FDA tells us to? Well, I don't think we do. I think Michael's already gone through the obinutuzumab and shown how effective it is, that you can get if you use chlorambucil and rituximab on the left versus what they call GA101 or obinutuzumab with the chlorambucil, a very significant difference and a significant prolongation of progression-free survival. As Dr. Johnson mentioned, progression-free survival means the time from when you start until you get a response and then it begins to regrow. So that we're convinced as well that the obinutuzumab is the best of the antibodies that attacks the target of rituximab called CD20, which is on the surface of the CLL cells. And again, to get to the point where you can't find any remaining leukemic cells, this antibody is better at doing that than the ibrutinib does. So it's more effective in clearing it. So if you can't get access to ibrutinib, there are a number of antibodies that might be available to carry you along until we can develop things such as that. The other study that was alluded to that's just been published in Lancet was the chlorambucil versus chlorambucil and the other anti-CD20 antibody called ofatumumab or Azera. And it had a very similar outcome to the GA101 with a prolongation of the outcome compared to chlorambucil alone. The missing arm here, however, is ofatumumab by itself. So ofatumumab by itself would be better than chlorambucil, but do we know that chlorambucil actually adds anything? It's an alkylating agent. It's oral, it's cheap, so the regulatory agencies love it. However, it does damage DNA. It does cause second cancers. So it would have been nice if that had a third arm that just looked at the antibody to prove that chlorambucil didn't do any bad things, because I'm not sure that it did very many good things. So the standard, the watch and wait. I would encourage you to be grateful that you're in the watch and wait group because by and large they have a pretty good quality of life. It's not a good thing to have the ticking saying I've still got this disease, but I would encourage you to be patient, as Michael said, because I think in the next couple of years we'll be able to figure out how to make that go away. So when we start to look at things, the young fit group of patients that's now been established, I think quite clearly, FCR better than BR, BR better than fludarabine and rituximab, and now the question is what we do next. Now this drug ABT-199, for example, if you're treating patients with ibrutinib, and you're left with a reasonable number of cells left behind. What you have is a mixture of CLL cells and normal B lymphocytes. The normal B cell lives on average 7 days. The average CLL cell will live 100 days. And it's kept alive by these survival proteins such as BCL2. And what happens with the ABT-199 is that it blocks this survival family of cells so that at the present time what we have to do is to put patients in hospital. We give them a 20 milligram tablet and tell them to read the newspaper. Every couple of hours we check their blood to make sure the cells are not dissolving too quickly to be dangerous. And then the next day they leave the hospital, their white count's gone down by 50%, the lymph glands are shrunk by about 30 to 50%, and then we gradually escalate it to what we think is a reasonable target dose of 200 to 400 milligram per day. And as you can see here, it achieves complete response. To have a complete response means that you have to normalize the bone marrow as well, so that it's more effective in doing that than anything that we've seen before, even some of the 17P group and those that are refractory. The other thing is that ibrutinib is not terribly effective in getting rid of the bone marrow infiltrate. And in the waterfall plot that you see on the left, the bone marrow infiltrate has more than a 50% reduction after about 6 months of treatment in about 90% of patients, and true complete eradication of the disease occurs in a reasonable number of patients. So the question is, what's the best thing to combine with ibrutinib or combine with the ABT? And one of the things that Dr. Gandhi has been doing is that because the ibrutinib-treated patients have circulating cells, you can take cells that have already been exposed to ibrutinib and test it by adding other agents. And there are only 2 agents that Dr. Gandhi has been found to be very effective in increasing the killing of those cells, an ABT-199, which is now called venetoclax, venetoclax. And you can remember that because Veneto is the wine-producing area around Venice, and so it's very close to my heart. The other is a drug called carfilzomib, which is very, very effective in interfering with the NF-kappa B pathway, which is involved in a lot of different cancers, and it's an oral medication that's very effective in multiple myeloma. One of the things that you've heard a lot about is these chimeric antigen Tcells. Now, the Tcells are the cells that identify foreign cancer cells and want to get rid of them. The other family of cells is natural killer cells. A chimera is a mixture of 2 genetic subsets. So what you do is that you take the T cells and then you incubate them with either a virus or electroporate them and shift a genetic sequence in that then gets into the genetic makeup of the patient's immune cells. And then you expand them up 1,000-fold, taking them from 100 million to 100 billion cells over a period of about 3 to 4 weeks, and then you give them back to the patient. The patient has developed a receptor which attaches to the leukemic cell, blows holes in them after a couple of weeks, and a number of patients can have very sustained, that is 3 to 4 plus year remissions free of recurrence of the disease. So it's doing what a stem cell transplant does with much less toxicity, and there are a whole bunch of areas that are being looked at now, a number of pharmaceutical companies that are getting into the mix. The other is a group of drugs that are called checkpoint inhibitors. So this is the T cell there, and then there's dendritic cells and tumor cells and macrophages that Dr. Halleck alluded to. And there is this tremendous dialogue that goes on between the microenvironment and the tumor cell in the lymph glands and other places. And all of them have these stimulating molecules and neutralizing molecules. There is a guy who's now working at our place, Dr. Allison, who's going to win the Nobel Prize because he figured out how to unlock the T cells so that they can attack the cancer cell. And ipilimumab has now been approved, and it's taken the long-term survival of extensive malignant melanoma from 3% to 20%. When you add nivolumab, the PD-1 antibody that's also approved, and do the 2 together, it takes it to 35%. And for the first time now, we have access to this group of drugs so that we have 4 protocols around, and I'm certain that we'll be able to activate the T cells to kill off the CLL cells in a reasonable number of patients and potentially eradicate the clone. So these are the group of antibodies that we're going to be looking at. I just mentioned earlier that if anyone wants to get a copy of the slides, I'm happy for anyone that wants to waste their time going through them to get a copy of the slides. Some of the academics that don't have anything else to do during their life might want them, but as patients, I wouldn't bother. So the situation's now very easy. Years ago, in the 70s and early 80s, we had chlorambucil plus or minus prednisone. It's like going to a fancy restaurant and you can say, I'll have a hamburger or a cheeseburger, and that was all that was on the menu. But now look at what's happening. These are all different target areas: chemoimmunotherapy, different antibodies, the inhibitors of the signal transduction, the microenvironment, the inhibitors of signaling pathways, aberrant CD53, apoptosis pathways, T-cell, etc. So if you think it's difficult deciding what to buy your mother for Mother's Day or your wife for Valentine's Day, think of how damn hard it is for us to figure out how to combine all these drugs and get the resources to do the clinical trials to do it. But I told some patients a few years ago that by August the 31st in 2015, I thought we would have all of the tools in place to cure the majority of patients with CLL. I think the time is now. I think we have all the tools. We have all the patients that want to participate. We have the pharmaceutical companies that have finally got interested in CLL. And we have investigators who, if the bureaucrats would leave it alone, would actually fast-track the cure of CLL, so that most of you will be coming along to this conference in 20 years and saying, remember that lunatic in 2015 who thought we'd be around? Thank you very much.
I don't think you're a lunatic. No. That was another fantastic talk, bringing up even more options that are coming our way into clinical trials and hopefully into the clinic. Again, we're going to try and squeeze in a couple of questions before we move on to the next speaker to try and take advantage of the time we have with Dr. Keating. That's great. Thank you.
Hello?
Oh, this microphone works better. I really enjoyed your talk. I just wanted to ask you, how do you define a Bruton failure? So if you've been on it for a year and it's worked really well, and then all of a sudden you have some lymph nodes that have come back, but 90% of them have shrunk, does that mean that you've failed it and that you need to add another drug to it or go to another therapy altogether?
Possibly. One of the things that should happen is that the cells that are there should be reevaluated, because there may be other causes of the cells beginning to grow in a particular area. And in particular, if you have the genetic analysis before you start ibrutinib, you should compare it to what's happened subsequently, because there are evolutions into different subtypes. We know that some of the Richter's transformation, for example, are triggered by reactivation of the Epstein-Barr virus. And that's just lurking there waiting to start growing some cells. But some of those patients actually then subside. So it doesn't automatically mean that it's doom and gloom. There is a paper from our institution that says that the survival of patients that fail ibrutinib is disastrous. Well, the reason for that was that we had no other options early on, so we didn't want to take them off. So we left them on the drug too long, so that I think in the new era, the outlook is not nearly as bad. The other is, the analogy is that everyone used to say if you failed a stem cell transplant, it was disastrous. But we've just recently published that the average survival of those patients who fail an allogeneic transplant, in our experience, is around about 4 years. So that everything's changing. So just don't assume that, okay, let's order the black armbands. It's all over. Break out the old wine and drink it before they put me in the box.
Thank you.
And that's a marker for who's it going to work in. In other words, afterwards you can figure out, well, these sort of people, this drug worked or this one worked. So when are we going to start to see that individualized, you're better with this type of therapy, your CLL's better with this one? Right now we're still lumping everybody into these protocols, and I think cure is there, but you got to be logical and compelling in how you put them together.
Well, just because you have a mutation doesn't necessarily mean that that mutation is what's driving the abnormality. Because oftentimes you can have 4 or 5 different mutations in the same cell. And to figure out which one is the most important driver, or if there's something else that's driving it other than those, is really very, very complicated. So there's been a tremendous amount of work so far which hasn't necessarily led to the breakthrough that we'd actually hoped would occur. It's getting there, but so far I think it's about 5 years away from the point where the hopes that we had will actually be brought to fruition.
One more, I think.
Thank you so much. My question is that for unmutated frontline treatment, do we go through the same process as looking at the same things, or is there one kind of treatment that is more advisable for unmutated, treatment naive?
Well, the unmuteds actually have, each of the unmutated group have a very different clinical outcome. So that was just the first cut of separating them out. So that I think we're actually going to have unmutated 11Qs, unmutated trisomy 12s, unmutated 13Qs. So as time goes by, we'll be coupling the mutation status and other genetic features. So right now, we're putting everyone on whatever we can do front line. So there's a new inhibitor of the Bruton's tyrosine kinase, ACP196. So that's sporadically open for frontline patients. We have an idelalisib plus rituximab subset. So we're trying to figure out what we can do until we have a lot more information on whether there's a unique relationship with some of these drugs to the genetic makeup that we have. So I think we're going to be in a bit of a sloshing around time for the next 12 months until we get a range of different combinations.